Vivian and Rich, for inviting me to do this talk. I'm excited to talk about this topic, and we're very appreciative of our collaboration on taking care of the kidney transplant patients together in the hospital. So we very much thank you for that. So on that note, I'm going to share my slides here. And I just want to make sure that everybody can see the slides and hear me okay? Excellent. Okay. All right, so our purpose here today is to talk about the management of kidney transplant patients um, for internists, so primarily in the hospital, what things that are important for you to look out as you continue as you manage these patients. Primarily, you're seeing these patients 6 months post transplant, 6 months and beyond, and so I kind of went to go over different topics that are important for you to be aware of. So this is my outline. We're going to go over some background information, surgical techniques and complications, focus significant time on immunosuppression and the side effects of the medications we use for maintenance immunosuppression, acute kidney injury and how to break that down in a transplant patient, biopsy, what to expect for complications after a kidney biopsy because you help us take care of these patients, some major medical complications to focus on, and what to do in the situation when the kidney has failed and our patients are facing returning back to dialysis. And so just as a way of background, we know that there are 5 stages of kidney disease, and as well as which are sort of subdivided into different stages of albuminuria, which can predict risk of progression. And indications for kidney transplant listing and evaluation are when the eGFR hits 20 cc's per minute, or when we have a patient who is actually end-stage kidney disease receiving renal replacement therapy. Now, once they get listed, most of the patients are already on dialysis, but if they are pre-dialysis, we usually try to wait until the GFR drops between 10 and 15 to sort of intervene to have the patient receive a transplant before they need dialysis. And there are various different causes of kidney disease, but by and large, the most common type of kidney disease causing kidney failure is diabetes, followed by hypertension, and then glomerular nephritis, and other causes. A large portion of that other is polycystic kidney disease. As over time, as we look to the future, to 2030, the population trends will tend to increase the incidence and the prevalence of end-stage kidney disease. The incidence of end-stage kidney disease is projected to rise between 11 and 18% between 2015 and 2030, and the prevalence of end-stage kidney disease may rise over 30% in this time period. So we're going to see a lot more patients with end-stage kidney disease. For patients who are in stage 5 kidney disease and are needing renal replacement therapy, we have different modalities, including dialysis, which is hemodialysis, which can be in-center or home, peritoneal dialysis, kidney transplantation, and of course, there is conservative care. But as you can see, that, transplantation is less than 50% here in the green color in patients who are 45 to 75 plus in age. It's really in the younger patients, certainly the 0 to 17-year-old patients that have a predominance of transplant as the primary mode of renal replacement therapy. And then in this 18 to 44 age group, it's about 50-50. So that being said, kidney transplants are on the rise, and kidneys are the most transplanted organ in the US, and this compares kidney transplantation as compared to other organs, including liver, heart, and lung. And part of the reason that the kidney is the most transplanted organ, of course, the high incidence of end-stage kidney disease, but also that we have, a donor dies, there are two organs typically that can be transplanted. Also, that our organs are very resilient and can sustain long cold ischemia times, unlike other organs. And also that we have living donors as well that can donate a kidney. So as of 2021, 250,000 people were living with a functioning kidney transplant, and we hit over a total of 25,000 total kidney transplants in 2022. Despite the increase in kidney transplantation, there is a growing wait list and long waiting time. So here you can see for kidney, this is in 2021, that the waiting list was, over 90,000. And because of that, in densely populated regions like California, the waiting time for a kidney transplant is quite long and is stratified by blood type. And so blood type O's have the longest waiting time at 10 years, and ABs have the shortest waiting time, around 5 to 6 years, but it's still quite a long time that patients are waiting on dialysis for a kidney transplant. So, what are the benefits of having a kidney transplant? Of course, from our patient perspective, freedom from dialysis, a less restricted diet, improved well being, returning to the workforce, more cost effective than remaining on dialysis, even though there's an upfront high cost of transplantation, and also that fertility also can return. But by and large, the reason that we perform transplants from it, the major benefit is that kidney transplant recipients have a longer life expectancy compared to those on dialysis. And here you can see a breakdown by age, looking at the life expectancy of dialysis patients in orange as compared to transplant patients in blue. And you can see that there's about a 2.5-fold increase in remaining years of life in a patient who has received a kidney transplant as compared to those who have remained on dialysis. And you can see that the benefit is really profound at the younger ages of life, between in your 20s and 30s. The benefit is even more profound than later in. So that was by way of background. Now let's move into some of the content. So let's start with the surgical techniques and the complications. So this is the standard anastomosis. Looking at the three major anastomoses are between the donor renal artery and to the recipient external iliac artery, the donor renal vein to the recipient external iliac vein, and the donor ureter anastomose to the recipient bladder. Some issues that we face is that we need to make sure that the vessels are not calcified from either longstanding diabetes or long dialysis vintage. So prolonged time on dialysis can cause vascular calcification. And so we typically will need to get a CT scan pre-transplant to make sure that these vessels the surgeons are able to make that anastomosis. Another issue is that our patients face long times on dialysis, and they're usually anuric. And so the bladder becomes contracted and small. And so it's difficult sometimes to make the anastomosis between the donor ureter and the recipient bladder. Occasionally, the donor has multiple renal arteries, and that can pose additional risks of complications, including higher risk for thromboses. So when there are multiple vessels here, we typically will put patients on aspirin to prevent, thromboses at these multiple small anastomoses. But some things to keep in mind with this surgical technique. Occasionally, we use what's called en bloc kidneys, which are dual kidneys. In this case, the donor, typically it's usually very young donors under the age of 2. And in that case, the kidneys are transplanted en bloc with the donor aorta and vena cava. So the donor aorta will be anastomosed to the recipient external iliac artery, the donor IVC to the recipient external iliac vein, and both ureters anastomosed to the recipient bladder. This is technically more complicated and requires careful positioning to avoid kinking of the vessels. The surgical complications, some of these are more acute surgical complications, which occur, in the first month after transplant. So typically not on these patients won't be on the hospitalist service, but just good to keep in mind that there are urologic complications, including urine leaks and obstructions. So urine leak is when the ureter actually has a break from the bladder, and the urine actually moves, kind of is extra. So the kidney is placed extraperitoneal, and so when there's a breach in the anastomosis from the donor ureter to the recipient bladder, there's spillage of urine into the extraperitoneal space, which can cause a lot of irritation to the peritoneum. So it usually presents with a triad of acute kidney injury, decrease in urine output, and abdominal pain. From a vascular standpoint, we see renal artery and vein thromboses about 2% of the time. Renal artery stenosis is more common, 10%. We get all sorts of fluid collections, including lymphoceles, hematomas, and seromas. Some of these will resolve on their own, but when they compress any of the vessels or compress the kidney, it can cause acute kidney injury and dysfunction. And then certainly wound infections. And we see a lot of lateral femoral cutaneous nerve palsy, which causes numbness in the sort of the anterior and lateral femoral region. So I'm going to spend a significant amount of time here looking at immunosuppression because our patients are on maintenance immunosuppression for the entirety of the time they have a functioning kidney, and they do have a lot of side effects that are important to keep in mind. Just by way of background, we use induction immunosuppression, which just means intensive immunosuppression at the perioperative time period. There are three primary agents that we use, two typically here that we use at USC. So thymoglobulin, which is a T cell depleting agent, and basiliximab, which is an IL-2 receptor blocker. Alemtuzumab is not used primarily here, but it is both a T and B cell depleting agent. The maintenance immunosuppression is broken down. So now moving to maintenance immunosuppression, there is broken down into our calcineurin inhibitors and anti-proliferative, prednisone, mTOR inhibitors, or belatacept. And our patients are typically on 3 of these medications at one time. And typically it's a calcineurin inhibitor, an anti-proliferative, and prednisone. But let's go through these a little bit more detail. Now, I know this is a very busy slide and may not be what most of you guys want to see, but this is just looking at a breakdown of how our T cells get activated by an antigen presenting cell. So when we place the kidney, the donor lymphocytes will move out of the kidney into the secondary lymphoid regions like the spleen and the lymph node, and the recipient antigen presenting cells and lymphocytes will move into the graft. And so you can get antigen presentation from your antigen presenting cells present the peptides to the T cell, and it needs 3 different signals to get activated: signal 1, signal 2, and signal 3. And so the crux of the maintenance immunosuppression is that it attacks these different signals to inhibit T cell activation. And so our cyclosporin and tacrolimus inhibit signal 1, belatacept inhibits signal 2. At signal 3, we have sirolimus, everolimus, cellceptor, myfortic, and imuran, which all sort of affect the signal 3 pathway. So breaking calcineurin inhibitors down, cyclosporin is an older calcineurin inhibitor. Now most of our patients are on tacrolimus. Cyclosporin binds to immunophilin called cyclophilin, and the combination of cyclosporin and cyclophilin binds and blocks calcineurin. And so that ends up preventing dephosphorylation of NFAT, and that in turn inhibits activation of the promoter for IL-2 gene, which is needed for T cell activation. And similarly, tacrolimus, although it binds to a different protein, the same sort of pathway occurs. This also inhibits the promoter of IL-2 gene needed for T cell activation. I wanted to make a point about the different formulations of tacrolimus and long-acting tacrolimus, which is called, which we use often, is under the brand name of Envarsus. So they're both approved to be used for both de novo, so right away after transplant, and for maintenance immunosuppression. Tacrolimus is immediate release and is dosed twice a day, 12 hours apart, whereas Envarsus is dosed once a day. And there isn't, you know, the studies have showed that there is improved neurotoxicity with switching to Envarsus as compared to tacrolimus. Primarily headache, tremor, insomnia, those sort of symptoms are better. And it's thought that it's because you don't have this additional peak in the evening. You have this peak in the morning after taking the drug, but then you don't have the evening peak. And it's thought that these peak levels are which contribute to neurotoxicity. Um, and so we check 12-hour troughs for tacrolimus, and we do 24-hour troughs for Envarsus to monitor drug levels appropriately. And over here, I just want to point out that they're not a one-to-one conversion. You can see these are area under the curve graphs here that are looking at the body's total exposure to the drug. And you can see that when you have an 85% reduction in the total daily tacrolimus dose, you have similar area under the curve. So we do a dose reduction of about 75 to 80% from the total tacrolimus to get the total Envarsus dose for the day. Some important side effects of these two medications. I've highlighted here the sort of comparison. So gingival hyperplasia is something that is uniquely seen with cyclosporin. And there's differences in hirsutism and alopecia, actually. So tacrolimus, you get alopecia as common side effect, and hirsutism, it can be seen with cyclosporin, which are opposites, obviously. There's less neurotoxicity with cyclosporin and more neurotoxicity with tacrolimus. And so we will switch our patients from tacrolimus to cyclosporin if they're having, very severe neurotoxicity like hallucinations. And an important difference too is that tacrolimus has a higher incidence of new onset diabetes after transplant as compared to cyclosporin. One important and very severe side effect of calcineurin inhibitors is posterior reversible encephalopathy syndrome. It's about 0.5 to 6% incidence among solid organ transplant recipients. The clinical presentation can be quite severe, with altered mental status, seizures, visual loss, or more milder with headache. On CT scan, you can see symmetric vasogenic edema, actually, apologize, not on CT, actually an MRI. MRI, you can see this vasogenic edema. And just keep in mind that even if you don't have super therapeutic levels, you can, or very high levels, you can still get this PRES syndrome. And of course, we should discontinue the agent if this does occur. So now we're switching from calcineurin inhibitors to antimetabolites, and this is an older drug that we use rarely, I would say. Primarily, we're using Cellcept and Myfortic, but azathioprine is the prodrug of 6-MP, and it metabolizes to TIMP, then to 6-thioguanine, and 6-thioguanine interferes with DNA synthesis and purine synthesis. And just a reminder that this drug is contraindicated with usage with xanthine oxidase inhibitors. And the reason is that you can see that there will be severe bone marrow suppression when both of these drugs are used at the same time. Mycophenolate, mofetil, and mycophenolic acid are both Cellcept and Myfortic, and both drugs inhibit and also IMD, which inhibits purine synthesis without incorporating DNA and incorporating into DNA. So the major difference between azathioprine and your Cellcept and Myfortic is that the GI symptoms are much better with azathioprine. You do have to be careful with liver toxicity related to azathioprine. And again, I mentioned that it is contraindicated to use with xanthine oxidase inhibitors. Both azathioprine and celseptin myfortic will have a bone marrow suppression. mTOR inhibitors are both sirolimus and everolimus. There are two formulations. They bind to FK binding protein 12, which complexes to the mammalian target of rapamycin, and again decreases IL-2's ability to stimulate T cell proliferation. These drugs are really hard for our patients to tolerate. There are a lot of side effects. Typically, can be lower extremity edema, proteinuria, hyperlipidemia. Um, Important is delayed wound healing. We can't use this drug in the early post-transplant period because of wound healing concerns, and also mouth ulcers as a very common side effect. One very important side effect to keep in mind with this drug that can be quite severe is pneumonitis and interstitial lung disease. Patients present with fever, cough, and dyspnea, CT chest with bilateral infiltrates and granulous opacities, and can be diagnosed with BAL cytology showing lymphocytic alveolitis. And then finally, belatacept is a fusion receptor protein of human FC and CTLA4 with affinity to CD80 and 86. So this is signal 2, which is also needed for T cell activation. And so it's an IV medication used when we want to avoid calcineurin inhibitors for various different reasons. It can be used de novo, so right after transplant, and as well as a maintenance drug. And as a maintenance, you'll see that our patients are getting it roughly about every month, which can be done as an outpatient. So I want to focus on two issues after regarding immunosuppression. So first will be what to do in sepsis, and another is when our patients are NPO. Unfortunately, there are no consensus guidelines on what to do when a patient is septic or has a severe infection. There's no consensus guidelines on which medication should be stopped or reduced and for what duration. So I know that our hospitalists always consult transplant nephrology for all of our patients, but this is one of our main jobs and priorities is to titrate and adjust immunosuppression in the setting of sepsis and balance the risk of infection and the risk of rejection, which is unique to every patient. So sometimes our patients are NPO for various different reasons, and we need to convert their maintenance immunosuppression to different medications that they can take. And so oral Cellcept can be switched to IV Cellcept. There is not an IV conversion for Myfortic, but we can use IV Cellcept. And the conversion is 1-to-1 from oral to IV. You're well familiar with IV methylprednisolone, which can be converted from PO prednisone. So 5 of PO prednisone is equivalent to 4 milligrams of IV methylprednisolone. There are formulations of both IV tacrolimus and cyclosporin. There's about a 1/3 dose reduction from oral, but it's very easy to overdose with the formulation. So we want to kind of err on the side of caution and monitor levels very closely. And then so it's your high risk for having the toxicities from the medications like nephrotoxicity and neurotoxicity. Sublingual tacrolimus is an easier option. It's about a 50% dose reduction from oral, but again, it does have erratic absorption and unpredictable drug-drug interactions. But we tend to use sublingual tacrolimus more than IV. Another major issue with immunosuppression are which drugs interfere with transplant immunosuppression medications. And primarily, the issue with drug-drug interactions have to do with the fact that calcineurin inhibitors and mTOR inhibitors are metabolized by the CYP3A isoenzyme, both the 5 and 4. Which are in the liver cells and intestinal cells. And so when we have drugs which inhibit this enzyme, we get increases in the drug levels of calcineurin inhibitors and mTOR inhibitors. So these are very common agents that we see in the hospital for primarily amiodarone, macrolide antibiotics, non-DHP calcium channel blockers, and then just azole antifungals. Those are very common drugs that we see that can have drug-drug interactions. So I want to make sure that you keep in mind this list of medications. And then on the other side, we can have drugs which actually sort of speed up these enzymes and actually decrease serum concentrations of calcineurin inhibitors and mTOR inhibitors. And so some medications that can actually decrease the drug levels of calcineurin inhibitors and mTOR inhibitors are anti-seizure medications, nafcillin, the rifampins. These are the primarily medications that you will see in the hospital. And so, what to do when you actually have these medications that you need to use? So, primarily for your macrolide antibiotics, which interact with both calcineurin inhibitors and tacrolimus, there are, other than for erythromycin and clarithromycin, there are recommended dose reductions, which range from anywhere from 35 to 50%, versus for azithromycin, we can just monitor. For your azole antifungals, you're going to have significant dose reductions, typically around 50%, for all your azole antifungals, except for isobuconazole, which you can just monitor for. The statins, they primarily have interactions only with cyclosporin, not tacrolimus. And so there are maximum doses of each statin that can be used, and we want to avoid lovastatin entirely, as well as pitavastatin, which I have not used before. For both antiarrhythmics like amiodarone and diltiazem, amiodarone, and then our non-DHP calcium channel blockers, diltiazem and verapamil, those you can typically monitor, and you don't need to preemptively do a dose reduction. And then rifampins, which are common TB drugs. Rifabutin has the least drug-drug interactions, and you can just monitor. But for rifampin, there is a recommended increased dose of 1 to 2 mg per kg per day if you need of tacrolimus and cyclosporin. Cyclosporin, but tacrolimus we would just monitor for. So just some important drug interactions of medications that we use very frequently in the hospital. So next I'm going to switch gears to acute kidney injury. And so for our patients who have a kidney transplant, we want to think about all the causes of acute kidney injury that affect our native transplant, native kidneys, but also add to that differential diagnosis this sort of additional list that can affect kidney transplant recipients. So I like to use this acronym called serum creatinine rise, SCRI. And so there are structural causes of AKI, including arterial and venous thrombosis, transplant, renal and iliac artery stenosis, obstruction and AV fistulas, CNI toxicities. R stands for rejection and recurrent disease, and infections, primarily adenovirus, BK, and CMV. We'll go into detail about each of these in the subsequent slides. But just know that AKI is common and has high risk to require renal replacement therapy in kidney transplant recipients as opposed to our non-transplant patients with AKI. So this is a very common finding. About 10% of patients will have renal artery stenosis or iliac artery stenosis. So these patients will present with worsening hypertension. And because of activation of the renin-angiotensin system, there's resulting fluid retention, so pulmonary edema, lower extremity edema. I've even seen a patient with a pericardial effusion. In addition, when they get started, if they happen to get started on an ACE or an ARB for blood pressure control, you'll see that there is an acute deterioration in the renal function afterwards. On exam, you may hear a renal bruit over the allograft. And just remember that even if you're very suspicious about this diagnosis and your renal ultrasound still doesn't show any renal artery stenosis, you could have stenosis more proximally in the iliac arteries. And so you might need to get something like a CT angiography to actually see that. So the classic ultrasound findings, though, are elevated velocities at the stenosis itself. And then distal to the stenosis in the intrarenal arteries, there's a tardus parvus waveform, which is this small amplitude that you can see in red and then prolonged systolic rise here in yellow. I mentioned here we have a picture of a segmental infarct due to a renal artery thrombosis, and you can see that there's a lack of Doppler signal in the affected region of the kidney. So every time we order a transplant ultrasound, it's with Doppler to make sure that we can assess for these vascular issues. And here we have hydronephrosis as well, looking and seeing here that this is a grade 2 hydronephrosis with dilated renal pelvis. So renal ultrasound is going to be the best initial imaging modality to assess for structural AKIs. And here we have an AV fistula post-kidney biopsy, and you can see that there's a high area of turbulent flow, both arterial and venous, in this area, which can happen after biopsy. So next is calcineurin nephrotoxicity. So despite tacrolimus and cyclosporin being really good agents at preventing rejection, there's a lot of toxicity associated with these medications. And so both looking at the glomeruli, the arterioles, and the tubulointerstitium, we see toxicity at every level. So these drugs can cause platelet aggregation and prothrombotic activity, leading to thrombotic microangiopathy in the glomeruli. We can see from various different mechanisms, we can see increased afferent arteriolar vasoconstriction. And within the tubules, we can see direct tubular toxicity, and which is seen as isometric vacuolization on our kidney biopsies. So all of this can lead to significant AKI. Next, R is rejection and recurrence of primary diseases. So I've highlighted here the diseases which are most common, have highest rates of recurrence. So the primary ones that we worry about are focal segmental glomerular sclerosis, and that's primary disease, which can occur in about 20 to 40% in the first transplant. And if it occurred in the first transplant, on retransplant, so the second transplant, the risk increases to 80%. It's typical that we do have treatments for this, so the likelihood of graft failure is still only 30 to 40%. MPGN, however, has a very high rate of recurrence and a high likelihood of graft failure. HUS, TTP, also has a fairly high rate of recurrence, around 40 to 60%, and occurs and causes graft failure in the set when it is untreated. It has a high chance of causing graft failure. And primary oxalosis, as well as an 80 to 100% rate of recurrence and a high chance of graft failure. So it's important to remember the initial causes of native kidney disease when assessing a acute kidney injury, if there's proteinuria, if there's hematuria, so that we can think about the recurrent disease coming back after transplant. Lastly is viral infections post-kidney transplant. I'm just going to focus mostly on BK, CMV, and adenovirus. So BK viremia and BK virus-associated nephropathy can occur fairly common and typically within the first 3 to 6 months, but can occur anywhere in the first year even. It occurs 8 to 15% for BK viremia and less so 1 to 7% BK virus associated nephropathy. It can present with hemorrhagic cystitis, ureteral strictures, and of course acute kidney injury and graft failure. CMV nephritis, although CMV is the most common virus after kidney transplant, CMV nephritis is actually rare. It can present with patients can be asymptomatic or have sort of the CMV syndrome, which includes diarrhea, fatigue, nausea, leukopenia, and in this setting, AKI. Adenovirus nephritis is far less common than BK, but I have seen about 5 cases of it myself. The patients present with fever, gross hematuria, and AKI. Typically, that's the triad. So just keep in mind if you have a patient who's on immunosuppression, especially within the first year, that these viruses can be a cause of acute kidney injury. So next, I'm going to focus on the kidney biopsy because you guys help us take care of so many of these patients. Our indications are unexplained proteinuria, acute kidney injury, nephritic syndrome, or abnormal rejection markers like cell-free DNA and donor-specific antibody. So more and more we're picking up on rejections when we have abnormal non-invasive rejection markers. So we check antibodies that the recipient has developed against the kidney allograft. And we also checked donor-derived cell-free DNA, and that is a marker of inflammation with it in the kidney, and we measure it in the serum. And when we see increase in this, it can be an early sign of rejection and a trigger to proceed with a kidney biopsy. Pre-biopsy considerations are going to be making sure that the platelet count is over 100, checking your coagulation markers. If patients have severe hypertension, hydronephrosis, urinary tract infections, and overlying skin infections, those would be reasons to delay a kidney biopsy or maybe treat those issues before proceeding with biopsy. The major complications of kidney biopsies are bleeding at about 1%, and the bleeding can occur in different areas and have different presentations. So in the collecting system, it will be hematuria. You can get a page kidney, which is bleeding underneath the kidney capsule, causing pain and hypertension. Perinephric space hematomas, and severe bleeding will occur if you puncture the renal artery. We typically monitor the hemoglobin very closely after the biopsy, and as a rule, if the hemoglobin drops by 1 or more, we'll get a stat ultrasound. Sorry about that. Another complication is developing an AV fistula after biopsy, which is also diagnosed by ultrasound. Most of these are silent and actually self-resolve, but it can be a cause of acute kidney injury after a kidney biopsy. So another thing to keep in mind. Rejection is a lot less common than it used to be. It's typically documented at 5 to 10% during the first year. In the past, it's been described as presenting with fever, pain, hematuria, oliguria, but typically now patients present with an AKI and are often asymptomatic, and may have abnormalities in these non-invasive rejection markers, as I mentioned. I don't want to go into the treatment of rejection in any great detail, but I just provided this so that you have a sense of how we treat these patients, what medications we're using, how long they may be in the hospital after a rejection. So if there's cellular rejection, we'll either use steroids or thymoglobulin, and just remember that we have to put patients back on prophylaxis. And if the patients are just getting steroids, we'll just use PCP prophylaxis and antifungal prophylaxis. But if thymoglobulin is used, we will also add valsite. Antibody-mediated rejection is very complicated, and there's lots of new emerging drugs that are being used, which I will not go through. But by and large, our standard treatments will be steroids, IVIG, plasmapheresis, and if patients are not responding to those therapies, we add things like rituximab or bortezomib. Next, I'm going to switch gears to medical complications and focus. There's many medical complications of transplant and immunosuppression, but I'm going to focus on three major ones: cardiovascular disease, infectious complications, and malignancy. And we reviewed just now briefly the immune-related complications of acute and chronic rejection. So the complications that we primarily see that can cause death actually are the main cause is cardiovascular death, followed by infections and malignancies. And you can see here by this graph that looking at the causes of death, both less than 1 year and greater than 1 year, both time points, although they're improving over time, cardiovascular death is the highest cause of death in a kidney transplant recipient. And so, what are the factors that lend to high risks of cardiovascular disease after kidney transplant? We, of course, have our traditional risk factors like hypertension, dyslipidemia, diabetes, obesity. But then there are non traditional risk factors in kidney transplant recipients specifically, including immunosuppression, like calcineurin inhibitors and steroids, rejection treatments, diastolic dysfunction due to long dialysis vintage. So, because of our long waiting times here in California, our patients are on dialysis for many, many years, 6 to 10 years, and they tend to have diastolic dysfunction from them, as well as mineral bone disease due to hyperparathyroidism. And so all of that leads to endothelial dysfunction, coronary calcification, and adverse cardiac remodeling. And ultimately, that's what we see in our patients is coronary artery disease, heart failure, pulmonary hypertension, and arrhythmias, which can significantly increase risk of cardiovascular death. So looking at hypertension post kidney transplant, causes are multifactorial, including native kidney disease, obesity, hyperparathyroidism, and immunosuppression, primarily prednisone and our calcineurin inhibitors, because they cause vasoconstriction and salt retention. And so the preferred agent to treat hypertension in our patients is a calcium channel blocker like amlodipine and nifedipine. We avoid verapamil and diltiazem due to the drug-drug interactions with our calcineurin inhibitors, unless we're purposely trying to boost the calcineurin inhibitor, which we do at times. So calcium channel blockers counteract the vasoconstrictive effects of these medications. Diabetes is quite common after transplant. So new onset diabetes after transplant is documented around 20%, and I think it's increasing now, can be documented up to 33% as a 2 to 5 year incidence. Risk factors, of course, our patients, especially, not all centers are steroid maintenance, but at USC, all our patients stay on prednisone maintenance therapy, unless there are certain circumstances. So that can certainly play a role. Calcineurin inhibitors, again, tacrolimus over cyclosporin, and that's because of reversible toxicity to the islet cells, which actually, reduce insulin secretion, and as well as obesity and hypomagnesemia. So there's no evidence on how to treat what is the optimal first-line agent to treat diabetes in our kidney transplant recipients. But the same drugs can be used that are used after in our non-transplant population. And just a word about SGLT2 inhibitors. There's emerging evidence for efficacy and safety in kidney transplant recipients, but at this time there has not been the same strong evidence that we see for native kidney disease for lowering risk of kidney failure and cardiac events. Hyperlipidemia, again, the medications all contribute, the immunosuppression, and then there are additional causes like nephrotic syndrome, diabetes, and obesity. Treatment is similar. Just wanted to point out again that the drug-drug interactions between statins and cyclosporin, which can lead to severe toxicities, including rhabdomyolysis. and that fenofibrates also have AKI due to proximal tubular dysfunction. So next I'm going to switch gears to infections. And so this is a breakdown of the infections that are commonly seen in our kidney transplant recipients by timeline. And so our hospitalists are taking care of the patients 6 months and beyond. And so the primary infections that we see are community-acquired pneumonias and urinary tract infections, and also viruses, particularly CMV, as well as opportunistic infections. And something to keep in mind is that our patients, because they're on immunosuppression, there is an impaired inflammatory response. And so sometimes diagnosis can be quite difficult, or they may not have the same sort of response that you would see in a patient who is not on immunosuppression. And so if you have a patient you really can't figure out the diagnosis, we recommend, sort of advocate for early invasive procedures like bronchs and biopsies and sampling of fluid collections to try to get exactly what infection is growing, and try to treat it aggressively, because our patients can decompensate very quickly. Risk factors will be, immunosuppression, if they've recently been treated for a rejection with a medication like thymoglobulin, plasmapheresis, neutropenia, and also immunomodulating viruses, which can also affect. I just wanted to put this up as our prophylaxis guidelines, just so you're aware of the prophylaxis that we use and the timeline. So fungal prophylaxis for thrush is nystatin for the first 1 to 3 months, and then we have PJP prophylaxis for about the first year. And then CMV prophylaxis depends on if the recipients are high, intermediate, or low risk, which has to do with the donor and recipient either having a mismatch or both being negative. And in the intermediate risk, they're either positive to positive or negative to positive. And depending on that risk, we will dose Valsite, typically Valsite, 900 milligrams for high risk, 450 milligrams for our intermediate risk, and 6 months for high risk and 3 months for our intermediate risk. And of course, your Valsite is renally dosed as well. And because pneumonias are one of the most common infection, I just wanted to break down causes of pneumonias that cause acute respiratory failure in our kidney transplant recipients. So this is 200 patients who got admitted to the ICU for acute respiratory failure for both infectious and non-infectious etiologies, but you can see that the primary causes are bacterial pneumonias, followed by opportunistic infections, and then viral pneumonias. Opportunistic fungal infections are primarily PJP, Aspergillus, and Candida. Urinary tract infections are quite common in our patients, and there are a few reasons for why this occurs. One is that there is a stent that is placed, and that's usually only for the first 4 weeks, 3 to 4 weeks actually. But then there are also additional factors that lend kidney transplant recipients to urinary tract infections. And one is that there's a short ureter, and these ureters typically have lost their sort of anti-reflux valves. And so it's very easy for urine to travel from the bladder through up the ureter and actually into the kidney and cause pyelonephritis. In addition, there's denervation of the kidney. And so our patients may not have the same symptoms as our patients with native kidney disease. Our common pathogens are E. coli, Klebsiella, Pseudomonas. And if you see a patient who is not responding to their appropriate antibiotic, even if you have culture and sensitivity data, it will be a reason to get an ultrasound to make sure that there's not an abscess or a fluid collection that needs to be drained in order for the patient to be cleared of the infection. CMV, as I mentioned, is the most common viral infection after kidney transplant with an incidence of 40 to 80%. Risk factors are going to be a positive donor, intensive immunosuppression, and peak incidences right after the prophylaxis is completed, whether that be after 3 months, 6 months, or 12 months post-transplant. And this tells you just the common symptoms that we see. GI symptoms are most predominant: leukopenia, thrombocytopenia, fever. And that's CMV gastroenteritis is the most common presentation, followed by pneumonia. And as I mentioned before, CMV nephritis is quite rare. Treatment is IV ganciclovir typically, or oral ganciclovir you can use if there's mild disease, so low viral titers, and if there's no GI involvement. If you have refractory disease, we do mutation testing and can use things like foscarnet and cidofovir. And there are emerging agents like letermovir and maribavir, which are currently being studied. And letermovir is approved actually now for prophylaxis in kidney transplant recipients. Last is malignancy. There is an significantly increased risk of malignancies after transplant, 10 to 15% at 15 years post-transplant as compared to 2 to 3, which is 2 to 3 times the general population. And the greatest risk is for viral-mediated infection and immune-driven cancers. So post-transplant lymphoproliferative disease, anogenital cancers, Kaposi sarcoma, and non-melanoma skin cancers are the most common. Of note, there's no increased risk of breast cancer and prostate cancer, which are common. So it's good that there's no increased risk there. And the highest risk of death is in melanoma, urogenital cancers, post-transplant lymphoproliferative disease. So I think we're hitting time. I know we started a little bit late, but I just have a few more slides on management of the post-kidney allograft post-failure. And so approximately 5,000 patients annually are returning to dialysis after kidney allograft failure. And it's a 5% of the incident dialysis population, and it's the fourth leading cause of end-stage kidney disease. 1 in 5 patients will lose their kidney transplant within 5 years, and over half will experience allograft loss by 10 years. And so the proportion of incident dialysis patients with a failed graft is increasing each year. And only 15 to 16% of those patients are actually going to receive a kidney transplant within a year after they return to dialysis. So a question to you guys is, which patient has the highest estimated risk for mortality? A patient with diabetes and on hemodialysis waiting for kidney transplant, patient with diabetes with a functioning kidney transplant, or patient with diabetes with a failing kidney transplant transition back to dialysis? Anyone have any idea? So,
Kathy?
yes, that's right. So patients with the same patient with diabetes, if they've got a failed kidney transplant or back on dialysis, have the highest risk of mortality. And so 10 years patients with a failed allograft have a 42% survival rate compared with 75% for those with a functioning graft. And the mortality for dialysis patients with the allograft failure is twice as high compared with the risk of transplant naive patients. So it's very significant when a patient has graft failure and is returned back to dialysis. And here you can see that diabetics and older patients have significantly higher risk of death post-graft failure as compared to those without. These are all the causes of late allograft dysfunction. Actually, most of these we've talked about in this lecture, but just wanted to summarize. And so this can be a very challenging time for our patients as they are, having to navigate advanced CKD management. We have to talk to them about adjusting their immunosuppression. We are asking them to be reevaluated for possible transplant. We ask them to find a living donor. There's also a lot of psychosocial stressors of having to have returned back to dialysis. And so it's a very challenging time for our patients. And this study just looked at, yes, there is a survival benefit in getting retransplanted, but that survival benefit decreases significantly as patients wait for an extended time period on dialysis for retransplant. So it's important to find a living donor so that they can limit their time back on dialysis. So it is a very difficult time for our patients. And so I think we need to do a better job. When our patients come in with a graft failure and we're initiating on dialysis, we're focusing on the medical issues like what to do with their immunosuppression, how to set up their dialysis. But we really need to focus on the psychosocial impact of this as well. We need to talk to our patients about having realistic expectations if they're really going to be a retransplant candidate, and go, really discuss with our patients the impact on their family, on their social functioning. There's high risks of depression in this population. And so I think this is a place that we can really strive to involve our, in addition to our social workers, but to really, involve our palliative care colleagues in this discussion. It can be a very challenging time, as I mentioned, and they can help with advanced care planning and discussions about serious illness. And so I think we need to do a better job of consulting you guys to talk about this in this situation. And so this just kind of finally reviews many of the considerations that we have with a patient who has a failed allograft. I just wanted to kind of summarize that sort of difficult time for patients and the importance of involving palliative care. I think that's all I have. At this time, I'd like to stop and take questions.
Dr. Voora,
Yes.
I have a question. Thank you for the presentation. It's really helpful. I was wondering for patient that has graft failure, and on dialysis, how aggressive are you on continuing the immune suppressive therapy? Like I have a patient that is on dialysis after graft failure, and now he's coming in with like a bowel perf and like sepsis. So like he has NG tube, and then we're not starting anything yet. I saw your conversion from like oral to IV, but we decided that we're gonna stop Myfortic and maybe when he tolerated more oral, like prednisone low dose, and then like low dose tacrolimus. But like since there's no benefit of the kidney um graft anymore, I know like in the future, if you're considered transplant, like you want to keep your suppressing the body. But what are your thoughts about this?
Yeah, there's actually a whole topic in and of itself. But briefly, um, if you have a patient that's starting back on dialysis after graft failure, you want to hold your anti-metabolite right away. And that's because the risk of infection outweighs the benefits of the medication. So that's going to be your azathioprine and also Myfortic. Um, then your tacrolimus or your calcineurin inhibitor or your mTOR inhibitor, whatever it may be, depends on if the patient is making significant urine or not. So if they're making a liter of urine, um, a liter or more of urine, you really want to preserve that because increased ultrafiltration on dialysis can be very difficult for patients to tolerate. So you want to preserve that urine. And so we will maintain low levels of the calcineurin inhibitor if they have significant residual urine output. So finally, you want to keep a little bit of prednisone, and that will be the last medication to wean. And it's typically a slow wean by 1 milligram every month or so. And the reason that we're very slow to decrease the immunosuppression is that we want to prevent something called graft intolerance syndrome, which is when your body all of a sudden recognizes that this is a foreign graft, and you can get a constellation of fever, allograft pain, hematuria, and that can, ultimately lead to need to have a graft nephrectomy. So not only is that another surgery for that patient, but if they are looking at retransplantation, there is the kidney sort of serves as a sort of sieve for these antibodies. And so when you do a graft nephrectomy, the antibodies level goes up quite high, and it can be very difficult to retransplant. You can kind of sensitize the patient again. So that's that's the main reason that we try to do this slow taper of immunosuppression. But overall, you should, especially in your patient who has a bowel perforation and probably has significant infection, must for sure stop your Cellcept or Myfortic. If the patient's making any urine, you might want to just keep low levels of tacrolimus. And if you can keep the prednisone on and there aren't significant infectious complications, then I would keep that on as well and slowly wean that later on.
Okay, thank you so much. Even though prednisone's at 5, do you still have to wean it down, or can you stop?
You would want to wean it down because they've been had that prednisone for many, many years. So you usually will do 1 milligram reduction by month.
Okay, got it. Thank you.
Anything else I can answer?
If no more questions, I know we're a little bit past the 1 o'clock hour. I know everybody's returning to their clinical duties. And so, is it okay if people email you with questions if
Yes.
they have any?
Yes.
Awesome. Thank you so much for your talk today. Really appreciate it. And for people with the CME and MOC credits, please look into the text box. Brandon has sent in the messages for how to do so. Thank you again, everybody, for joining today.
Thank you, Dr. Voora. That was very helpful. Thank you.